Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Welcome to today's webinar. PYA understands the importance of clear, relevant, timely information to the industries we serve. So we offer a variety of webinars, white papers, articles, checklists, and other tools, all for free. Subscribe to our e-newsletters, follow us on social media, and subscribe to our PYA Webinar Recast podcast series for audio-only versions of all of our webinars at pyapc.com. Thank you for joining us. Here are today's presenters.
Welcome to the 5th episode of the Revenue Recharge series, Payer Disputes. Today, my colleague Jane Jerzak and myself, Jason Hardin, will be discussing the topic of payer disputes between providers and payers. We will start by discussing common issues of payment disputes, then move on to best practices for resolution of payment disputes with payers, evaluate analytical approaches for dispute resolution, and end by discussing long-term strategies for monitoring payer contract performance to address payment issues early on before they become a prolonged issue. All right, I will toss it to you, Jane, to discuss understanding payment dispute dynamics.
Thank you, Jason. Welcome, everybody, to the broadcast. What we really wanted to discuss today is a very important topic relating to payer disputes. And here at PYA, we've been helping a number of hospitals with the challenges that they've had related to various payer disputes. So we're excited to share with you today, things that we've learned along the way that may help you as you work with your major payers on issues. So first, we're going to get into understanding payment dispute dynamics. The common causes of payment disputes, we see it all. But in terms of order of frequency, often we see downcoding of inpatient admissions to lower weighted DRGs. What was really reported, what was documented. So this is really a material cause of reimbursement reductions in the claims that we've seen getting disputed. We've also seen denial or underpayment of medically necessary services. And we have to remind the payer, it's really how the patient presented that's the key, not the final diagnosis. One of the examples I might cite is when a patient comes to the ER with chest pain. Well, a real workup is required for that presenting condition, chest pain. In the end, after the tests and procedures may have been done, that patient may have really been diagnosed with anxiety or some type of anxiety disorder. Well, all those services were necessary because of the presenting complaint, the chief complaint. And that should be pointed out to the payers if they really challenge the medically necessary services or things that, in a sense, may at the end might not have sounded so material, but when that patient presented, it was. We also see denials due to administrative policies, timely filing. And here we want you to make sure your payer contract is flexible. Even though most of your claims are promptly filed within the 30, 60, or 90 days, you want cushion. You want that 180 days to file a claim in your contract just for those weird cases, those secondary claims, etc. We also see payers moving some inpatient services to outpatient, even sometimes after that inpatient stay was prior authorized. And that's really frustrating because you go through your efforts of getting the stay authorized, and then at the end, the post-payment review comes and then that claim is downcoded. Again, it's the presenting patient's issue, not what ultimately happened to the patient. Denials for readmissions. Here, it's really, what does your contract state? What did you sign? What did you agree on? Then we're getting into some bundling and unbundling issues. For those of you that still have percent of charge payer contracts, or maybe percent of charge for outliers, we're seeing more and more bundling and unbundling challenges. And these are, in a sense, important to fight, because often what we're seeing is that the payers are using guidelines and, quote, authoritative literature that has no relevance, no authority to let them bundle. We're seeing where maybe the physician rules are pointed to when it's really a hospital inpatient claim. And the billing rules are not the coding rules. So there's a lot you can do to challenge the unbundling issues that many payers use, really in an effort to reduce your reimbursement. The last item is really that constantly changing payer policy issues resulting in underpayments. More and more payment policies, bundling more things, disallowing more things. And here, what we like to have you do is attach the payment policy when you sign your contract. What did you agree to? What were those economic terms, those economic bundling conditions in the contract that you signed? And then we like to put in the contract, if there was a material change in those payment policies that created a material reduction in your reimbursement, you have the ability to go back and adjust the rates for services that are paid. This is really important, especially in the professional world. Payers just aren't wanting to pay sick visits with preventative visits. They don't want to pay for things in the ER. There's just a growing number of payment policy issues. So unless you protect yourself in the contract itself and monitor it, you're going to continue to see a reduction in reimbursement on your claims. There's also coding and billing errors. Again, we're seeing maybe it's our fault as a provider, the use of incorrect CPT codes, incorrect diagnosis codes, or a combination that don't work with that particular payer. So let's make sure somebody in your organization owns and understands all of those nuances of all of your major contracts. Incomplete documentation, well, that's another area that really, to support your medical necessity, to support that you file the claim, you filed your appeal on time, you must be rigorous about the documentation that you keep. Contract disputes or contract discrepancies. Most of the time what we see is that the contract interpretations are guided primarily by the contract. And if there's a disagreement or an inconsistency between a policy and the contract typically rules. You need to really take advantage of that and make sure that the words and language in your contract protects you as much as possible, especially as it gets into those payment policies that the payers keep, in a sense, escalating, that are doing nothing more than reducing your reimbursement rate. There's rate disputes. What was really the agreed upon rate for services? Let's be clear. Let's make sure everything in your contract has a rate. Let's make sure your services in your contract have a default rate. In the event that there's really nothing else that you would be paid on in the contract. And here, I really like to insist on default rates, especially for outpatient or inpatient-only procedures. Services that for Medicare need to be done on an inpatient basis. Well, for other payers, maybe that can be done in an outpatient, that surgical procedure. If you don't have a rate in your contract for that inpatient-only procedure for a particular commercial payer, you may be getting 0 on that claim, or 0 for service for that procedure. I've seen it In fact, we have one client, they aggregated their claims that were not paid for inpatient only because the payer did not provide a rate for these new inpatient only procedures. So you really should protect yourself by having a default rate. We're also seeing a lot of retroactive denials. Claims are initially paid, initially authorized, but later upon post-payment review, they are in a sense pulled back. And this is very frustrating because it takes your time and your energy to do that. And Jason's going to get into some of those things. But those are things that we are seeing happen more and more. And it's things that you need to protect yourself on. And then, of course, the medical necessity denials. Make sure your hospital has a physician lead that's really working and interfacing with the payers to really challenge maybe what those, quote, peer-to-peers are saying. The peer-to-peer is often a misnomer. They're often not the specialist or the specialty that really is, in a sense, getting the claim denied. It might not be a CV surgeon. It might not be a vascular surgeon that's really trying to interpret what was happening. So really challenge who that peer-to-peer is when you're getting those medical necessity denials put in play. So those are really some dynamics, Jason, that we're seeing happen in payer disputes. I'm going to turn it over now to Jason, and he's going to walk through best practices for resolution of some of these payment disputes.
Thank you, Jane. So let's go through some of the best practices for resolving these disputes. Ideally, you would like to resolve the disputes through an informal discussion, an email, perhaps a negotiation with the payer. This doesn't always work. So if that does not lead to a successful outcome and the claims that you're disputing, perhaps sending a demand letter if the informal resolution fails. The demand letter needs to outline the dispute, the amount in question, and the desired resolution. It's important to make sure you gather sufficient documentation when you are disputing the claim. So you need to make sure to collect documentation such as the contract, the payment records, correspondence, and any other evidence that supports your case. Also, when you're evaluating the claims that you're disputing, if you can categorize after identifying the systemic issues and trends of the disputed claims. For example, Jane mentioned one of the common causes that we see in disputes is a downcoding of inpatient DRGs or denials or underpayments of medically necessary services, and then also disputes due to payers' administrative policies. If you can quantify the disputed amounts, the number of claims into these categories, you can structure your argument by category, and I think it's more digestible, easy to interpret, and track the resolution that you're making on those various categories. So some things to keep in mind as you go through disputing claims that you may have with payers. Those are two ways, more of an informal and formal approach to disputing. If either of those options fails, then perhaps you evaluate arbitration. Perhaps you evaluate your contract to see what your options are related to arbitration. But what you have to keep in mind is it's going to be time consuming and very resource intensive. So it's important to evaluate the time and costs associated with going down this path to make sure, do you have enough claims to make this worthwhile? So evaluate the disputed amount. What you would evaluate would perhaps be the success rate, what you would be happy with receiving out of the disputed amounts in question before you pursuing arbitration. Jane and I have both had experience serving as an expert witness on behalf of healthcare providers in arbitration matters related to payment disputes. And we wanted to kind of summarize the events that take place from our perspective and our involvement helping healthcare providers. So we start with sampling a population of the claims being disputed. That's sample number one. So if we have thousands of claims, we would look at several hundred claims out of those 1,000, and we would review in detail the claim documentation, draft a narrative of the timeline events that occurred. It's important to make sure that you have sufficient detail to be able to draft that narrative. So the importance along the way, before a dispute even arises, you need to make sure you're documenting claims, you have internal documentation in your system to make sure that you understand the appeals that are being filed, correspondence, calls, and notes. We may think 6 months ago, you may be able to recall through emails, they may not be archived at that point, what happened, what unfolded with that claim. However, we've worked on cases where it could be 5 or 7 years or more, depending on the statute of limitations and how long the dispute has persisted. It's challenging to remember half a decade ago the events that unfolded. Was the dispute timely in terms of the appeal that was filed related to that dispute? So these are things to keep in mind, and you should be doing on an ongoing basis in the event a dispute arises. The next step is repricing the claims. Many times there's a dispute related to the payment amount, the amount received versus the amount that the healthcare provider believes should have been received under the current contract. So independently repricing these claims to evaluate what should have been paid, and then comparing that to what was actually paid to arrive at a disputed amount. And then aggregating across all of the disputed claims what the total disputed amount in question would be. After that step, one thing you need to keep in mind is determining prejudgment interest. So not receiving the full amount over a 5-year period, well, there's some cost, the time value of money associated with that. Depending on the state, that interest rate may vary. Some states it's 12%, for example. So if it's 12% over, let's say, a 7-year period on the disputed amount, you can see that it can be a quite material amount in addition to the amount being disputed. So that's a step you want to make sure to consider and evaluate before you pursue arbitration. After you determine the disputed amount and calculate prejudgment interest on the sample claims, the next step is to extrapolate the disputed amount to the entire population of claims being disputed, so that you have the disputed amount in total. In addition to the research conducted, repricing the claims, we find that it's helpful to rely on market data if it's appropriate for the claims in question, and then also claims data, publicly available claims, such as the Medicare fee-for-service claims database. We find that to be a helpful resource. In addition to that resource, we also rely upon the publicly available price transparency machine-readable files to compare negotiated rates among providers and payers, and then also the Medicare cost reports for a variety of financial and operational metrics. So a few resources that are publicly available that may be helpful depending on the dispute in question. Next, I'm going to discuss analytical approaches for dispute resolution. There's a massive amount of data, as I mentioned on the previous slide, in preparing for dispute resolution. I'm going to share some of the approaches that we've implemented and suggest our clients to implement to appropriately dispute claims. So it starts with validating and organizing the claim details. It's a pretty big undertaking, especially when you look at the breadth of time. If you're going back 3, 4, 5, maybe 7 years of claims that you're disputing based on the dispute in question. So it's important to pull all of the details and validate that the details are appropriate. So looking at dates of service, the type of claim, is this inpatient versus outpatient? What are the total charges on the claim? The document reference, so having the appropriate EOBs, remittance advices, etc. We find that it's helpful to put in a spreadsheet what the allowed amount was per the payer so that we know what was actually allowed, and then independently computing the allowed amount by repricing each claim. It may not be appropriate to reprice the entire population of claims, but where I mentioned in the previous slide, taking a sample and repricing a sample of the claims and then extrapolating to the population. So instead of several thousand claims, we're looking at maybe several hundred, perhaps, depending on the size and scale of the dispute and the number of claims in question. We're able to arrive at the disputed amount by looking at the difference between the allowed amount per the payer and then the amount that's independently computed. There are a few ways that you can go about this. As I mentioned, it depends on that the number of claims being disputed, but to model and evaluate the financial impact of the dispute. As I mentioned, we'll independently reprice the claim to determine the allowed amount, to determine what the disputed amount is. It's ideal if you can pull the claim detail into a machine-readable format, such as Excel or CSV. That makes it easier to bump up or match against fee schedules. If you're not able to do this and you can only rely upon PDFs and the EOBs and claim detail, there's several tools that you can rely upon to extract PDF detail. It's just an extra step you need to go through to put into a machine readable format. So something to keep in mind as you prepare to dispute the claims. A few thoughts in terms of the size and scale of the tool you need to use. A few modeling options to consider depending on the number of claims being disputed. Option 1, you may input the claim detail into Excel and manually price using perhaps an online pricer. If it's a derivative of Medicare, you may price the inpatient or outpatient claim of what Medicare would pay and then multiply times the multiple for that specific contract, if applicable. Option 2, if you have hundreds or thousands of claims, perhaps manually pricing with the pricer is not feasible. You could bring in the relevant schedules per the contract and price the claims based on having the claim detail in a machine readable format and then looking up the appropriate values. Option 3, if you have tens of thousands or millions of claims, in some instances we've worked on multiple hospitals, a massive health system, we need more scale than what Excel is able to offer. Then we've loaded historical claim detail into a data warehouse. Then we have the ability to use query language called SQL, structured query language, to be able to define the logic to, at scale, reprice the claims to evaluate the overall disputed amount. One other step that we thought was helpful is, I mentioned earlier, organizing claims by dispute category. You may have some success in some categories versus others. As Jane mentioned, some of the contract terms could be gray. Maybe it's not black or white. There could be some ambiguity in terms of the interpretation if you pursue arbitration. So it may be helpful to assign some percentages to the likelihood of success in particular areas. If you organize the number of claims, the disputed amount based on category, you may be able to figure out the range of possibilities that you're prepared to compromise on so that you can arrive at a resolution with the payer. We find this to be a helpful exercise and worthwhile in the settlement process. It's important to note that you need to do this in collaboration with counsel because they're going to have a legal perspective on the nature of the dispute in terms of what the contract stipulates. So this is an important exercise to do in conjunction with counsel as you build this model. Next, I'm going to transition to Jane to discuss long-term strategies for provider-payer relationships. Jane, I will hand it to you.
Thanks, Jason. As you can see, working with payers and payer disputes is a complex process, and Jason explained it really well in terms of all the steps that we need to work with clients on to really help them get to a resolution that's a win-win for them. And really the overall goal is, hey, let's not get there at all. Let's see if we can develop a long-term strategy so that we can minimize the need to go through this laborious arbitration process. So how do we do that? Well, the first and most important thing is to monitor claims on an ongoing basis, comparing actual allowed amounts on those claims to expected reimbursement. This should really be standard work for your organization. What we have here is a visual just of a period of time to help understand what was expected on the claim in terms of reimbursement as a percent of charges versus what was actually received on the claims as a percent of billed charges by payer. So you can see in the last column What did we receive versus what did we expect to receive from each of our payers? And you should be doing this really on a monthly basis, analyzing what's really that gap between expected and actual reimbursement. You can see on this chart, payer C is pretty darn good. Their actual to expected is 98%, meaning our collections are 98% of what we thought it should be. But if you take a look at payer H, they're really one of your largest payers here in this example. They only paid us 92% of what we expected. Well, that 8% gap could be your bottom line. I mean, it's a very, very material item for many organizations. And if you look at the whole ball of this, you can see on average, your slippage, your reimbursement compared what you thought you were getting on the contract, which we all work really hard to get rates in a contract, versus what you're actually getting on claims is probably less than 95%. So again, that 5% difference could make or break your bottom line of your organization. So do this analysis at least monthly. And then, of course, you can drill down into a per claim basis. But, what can go wrong? What have we seen? You get the contract, you load the contract, you load the rates. We have seen everything. We have seen that the payer has loaded the wrong contract rates, just pure and simple loaded the wrong rates. Could have been for a different hospital. We don't know, but they're wrong. They're not what you agreed to in the contract. Many times we see the contract rates as are not updated. And according to the contract, those rates should be increased 3% a year, 4%, whatever the obligation is. Oftentimes payers forget, or they'll do it in, April rather than January. Well, you lost 4 months of that price increase, that reimbursement increase. That needs to come back to you. That was the payer error. The gap in contract language and services provided. And this I spoke to in the beginning of this session. One that really hits home is these inpatient-only services that are done in an outpatient setting. We're seeing this more and more, and it's a risk if you do not have a fee certain from your payers for all those outpatient-related services that really for Medicare are required to be done inpatient. Again, insist on a default rate to protect you in the event your payer is not on the ball and not giving you updates for reimbursing you on the outpatient basis for those claims that are inpatient only. Pay careful attention to your contract language. Ideally, the payment policies, as we said, should be attached to your contract, because we don't want these gaps to be payment policy driven that you did not have any control over. Again, all that would be is a reimbursement reduction. And you need to maintain economic equality with the contract that you agree to. And if you look at this chart, this does not speak to economic equality. It speaks to reimbursement slippage due to a variety of reasons. Maybe some was due to wrong coding or submitting the claim late on behalf of the provider. That could be the case, but some of it could simply be more and more line item denials or bundling of services or down coding on behalf of the payers. And so you need to get a handle on exactly where these gaps are, how big the gaps are between actual and expected reimbursement, and what component of those gaps are not your problem, and what you should go after and fight with the payer, talk to the payer about, in a sense, making a resolution on it. The other thing you should be doing is making sure you've got a hospital multidisciplinary team that really understands the key reimbursement systems for those major contracts. What are those revenue code, diagnosis code, HCPCS codes requirements for key services? Making sure that your service departments understand this, your scheduling departments understand this, your claims submission people. We all need to have a common understanding of some of these rules that are really going to be governing your reimbursement to make sure that your systems are up to date, your charge master, your coding systems are up to date to make sure that the way the claim needs to go in and the way the service needs to be scheduled and documented is in clear alignment with those payer policies. So it could be your systems at an issue or the payer systems or a combination. So definitely monitor monthly, and any of those variances, once you drill down by claim, figure out the root cause of those issues. Was it around contract loaded? Was it they didn't update your rates? There's all kinds of things. Or maybe your professional rates were updated, but they forgot to update the lab rates. This happens. We've seen this. And of course, really continue to have regular meetings with your key payers to discuss reoccurring issues. Keep these issues on a log. Keep all the claims aligned with these issues. Work these issues. Escalate if you need to with the major payers. Time is money, and the more months you do not get paid for some of these claim issues that are payer-driven, the more it's harming your hospital's revenue cycles. So you really do need to be diligent about monitoring this on a long-term basis. So in summary, the long-term strategy is all about prevention. It's promptly monitoring the difference between your actual payments and your contracted payments, and really working hand in hand with key payers to monitor these issues and to address these issues so that you get paid your fair share. Ideally, exactly what's in your contract. Ideally, exactly or even better than sample payers C, as you see on the page, where they receive 98% of their expected reimbursement. That's the best we've seen for this sample hospital. So that's our goal. Is prevention. Jason, I'm going to turn it over to you to close out our session on payer disputes.
Thank you, Jane. Thank you, everyone, for joining us today. If you have any questions on the topics related to payer disputes, please feel free to reach out to Jane or myself. And also make sure to join us for August 15th for the next Revenue Recharge series on value-based care. Thank you.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.